Everyone, so this is the chapter 37 mapping lecture for our vital signs and measurements chapter. And so I'm recording this because I think I'm going to end up having a sub. I got called for jury duty, and so just in case we have a sub that day, I wanted to put this lecture up so that you have it to reference and to go back to. So chapter 37 covers vital signs. It's a super important chapter. It's going to be the foundation for much of your lab work for the rest of the semester. You're going to be taking vitals on 4 patients a day, patients being one another. And so you will have to know how to do these vital signs. We're going to work hands-on with one another in the lab pretty extensively doing these, but before you can work with each other on taking the vitals, it's important to know the theory behind each of them. So we start, I'm going to see if I can blow this up a little bit. We start here with figuring out what the vital signs are, and those include these 4 basics, which are temperature, pulse, respirations, and blood pressure. And they are used to measure the body's basic functions, which are used to assess the general physical health of a person. And so the normal ranges for vitals vary with a person's age and their weight and their gender, and then their overall health as well. So there are several things that can influence a person's various vital signs. And so what may be normal for one person isn't necessarily the normal for another person. And so we'll talk about some of those different things that can affect the various vitals for different populations of people as we go along. Okay, so first we're going to take a look at temperature. There are several methods to take a temperature, and there are several types of thermometers that we can use to do so. So the first type is an electronic or digital thermometer, and that's the kind that you'll most commonly see these days. It's the kind that you use and it gives you a digital readout. So you don't really have to do a whole lot of overthinking with getting a result there. It just kind of tells you on the screen what the result is for the temperature. There are also manual thermometers. We use non-mercury manual thermometers now, and so that's what this little illustration that I drew over here is. It's kind of sloppy, sorry about that, but I will explain to you how to read those in just a second. And then there are disposable thermometers also. Sometimes you'll see those by way of temp dot thermometers or the sort, and so those are just one-time use thermometers. There are also several ways that we can take a temperature. We can do it orally, by mouth. Tympanic is ear. Temporal is where we scan over the forehead. An axillary temperature is done in the armpits, or a rectal temperature is done in the rectum. So talking about those manual thermometers, or those, I think there's probably a better term than manual for them. I don't know what the appropriate term or what the actual term for this type of thermometer is, but the thermometers, these type of thermometers require you to read the mercury on them, but mercury is supposed to have been done away with in 2017. So now the silver line is not actually mercury in them. It is supposed to be non-mercury. So the gist is still the same, though. You still actually have to read it at the silver line. And so when you're looking at these thermometers, the big line is a whole degree in each of the small line, and between the two big lines is going to be 0.2 degrees. So if you're looking at the way that this thermometer is set up, and so I drew kind of a bigger version of what's along the side of this thermometer over here. You have like 98 degrees, and then the first line, there's always 4 lines between 2 big lines, and the first line would be 0.2, so it would be 98.2, 0.4, 0.6, 0.8, and then the next big line would be 99 degrees. 0.2, 0.4, 0.6, 0.8, and then the next big line would be 100 degrees, and so on. And so you always want to read where at the silver line at the end of where it stops. So if I'm looking at this thermometer here, it looks like this would stop actually at like 102.246-ish right there. And so that's kind of how those types of thermometers are read. A couple of other things I already mentioned, that mercury is no longer used. We now have non-mercury thermometers to use. And when you're looking at the tips of these thermometers, a green tip would indicate that it's for oral use only, and a red tip on the end of this type of thermometer would indicate that it is for rectal use only. So some things to know about body temperatures. Afebrile is where the body is without a fever. And so the average body temperature for humans is 98.6 degrees Fahrenheit. But a normal afebrile temperature in a healthy person can range anywhere from 97.8 all the way up to 99.1 degrees Fahrenheit. And sometimes it can even get a little higher than that. And so if you're seeing any temperatures registering anywhere in that range, it isn't necessarily a fever for that patient. So if they're a little above 98.6, if they're right at 99, then that's not really anything to be super concerned with. Febrile is any temperature that is higher than a person's average body temp. Hyperpyrexia is an exceptionally high fever, so that's something that is potentially dangerous for the patient, and so we want to make sure we get that fever broke pretty quickly. Hypothermia is the opposite of hyperpyrexia, and that is a drop in the body temperature below 95 degrees. So a few more notes on body temps here, that they can vary due to factors other than illness or infection. And so all of these things are things that can affect body temperatures, things like stress and dehydration, exercise. Obviously, if you are outside and it's really cold, then it can bring your body temperature down. If you're outside and it's really hot, that can raise your body temperature up. Drinking a hot or cold beverage can have the same effect. And then also thyroid disorders can mess with your body temperature as well. And then one last note about temperatures in older adults. Older adults do not control their body temperatures as well as younger adults do, so they can be sick without ever actually showing signs of a fever. So that's something to keep in mind if you are working with an older geriatric population at your clinical site or in your place of employment. You want to keep that in mind, because they may never register a fever, but could actually be harboring an infection somewhere. All right, I'm going to scroll back up here, and we're going to actually go over to pulse. So the next vital sign is pulse, and that is the number of times that the heart beats per minute. And the pulse rates vary from person to person. It's typically lower when a person is at rest and then higher when they are exercising, and that is because the tissues need more oxygen, which it gets from the blood. So if you've ever ran up a flight of stairs, then you know that your heart starts pumping, and you can probably feel it bounding even a little bit once you get to the top of the flight of stairs, or if you've ever been on a long run or done any type of physical activity or exercise. The point is to get your heart pumping and to get that blood flowing, and so you can feel your heart pounding, and that is because your heart has kicked up a notch so that it can pump enough oxygen-rich blood out to your tissues to deliver that oxygen so that it can fulfill the needs of those tissues while you are exerting more force and using up more energy and those types of things. So I just lost my train of thought for a second. Anyway, the point is you need to have more oxygen delivered while you are exercising. Normal range for pulse is 60 to 80 beats per minute. Tachycardia is faster than average pulse. It can indicate health problems such as stress or dehydration, and infection sitting somewhere in the body. Also things like anxiety, a thyroid disorder, shock, anemia, and even some heart conditions can be indicated by tachycardia. Bradycardia is a lower than average pulse, and it may also be a sign of a heart condition. There are some meds, specifically digoxin and some beta blockers, that can slow the pulse down. Also, a lower heart rate is pretty common for those who exercise a lot or who are very athletic. It is not atypical for their pulse to be what would be normally considered to be bradycardic for a average person. So if you get a well-conditioned athlete and their pulse rate is in the high 50s or in the mid 50s at resting, then that is likely because they are a well-conditioned athlete. So pulses can be measured electronically in the fingers and the earlobes with electronic devices, or they can be measured manually by palpating at the various pulse points. And so, don't mind my little stick figure guy here, but at the various pulse points, you have a temporal pulse point, a carotid pulse point on the neck, a radial pulse point on the wrist on the thumb side. You have a brachial pulse point in the elbow, femoral, the very top inner thigh, popliteal in the knee, and then a pedal pulse point at the top of the foot. It's very easy to occlude the pulse point in the foot, so it's kind of hard to get a pulse there. The most commonly used in our line of work are the brachial, the radial, and occasionally the carotid. Oh, and you know what? I forgot to put probably the most important one in here. I cannot believe I forgot to put this in here. But so you should add this in here when you are making your own map. You should add in here that the pulse point for the heart is the apical pulse. I can't believe I forgot to put that in there. So there's an apical pulse in the chest at the heart. Okay, so over to respirations. Let me blow this back up here. I had to pause it for a second, and then I moved. So your respirations are the number of breaths taken per minute. So your normal respiration rate for an adult is about 12 to 20 breaths per minute. Some terms that you need to know regarding respirations. There is hyperventilation, and that is an excessive rate and depth of breathing. There's dyspnea, which is difficult or painful breathing. Bradypnea, which is respiration rate under 12 breaths per minute at a resting, like as the patient is resting, so not if they've been exercising or, they're in distress. It's just at a resting rate. So sometimes I've had patients here, I was taught to say these words, bradypnea and tachypnea, but since I have relocated to this side of the country, I have had students say that they were taught bradypnea and tachypnea, I think it was, hyperpnea maybe, instead of hyperypnea. So if you were taught to say them a different way, you can say them however you would like to say them, but I was taught bradypnea, tachypnea, and hyperypnea, so that is how I teach my students to pronounce these words. So somebody, if you were taught a different way from another professor, doctor, somebody correct me. So tachypnea is a respiration rate over 25 breaths per minute at a resting state, and hyperypnea is an abnormally rapid, deep, or labored breathing, and indications of possible disease should be noted here. So respirations can be affected by lots of things, just like the other vitals can, things like asthma, anxiety, pneumonia, congestive heart failure, lung disease, narcotic use, or drug overdoses can all affect breathing in patients. So a couple of breath sounds that you should know about. There are rhonchi, which is kind of a deep snoring, rattling sound. and it is usually associated with asthma, acute bronchitis, and a partial airway obstruction. And then the second one is called rales, and it is more of a crackling sound that is indicative of fluid in the lungs, and it's typically heard in patients with pneumonia, telextasis, and then pulmonary edemas. So just be mindful of those. Moving on over to the big guy over here. I got a whole half page of blood pressure stuff. So, blood pressure is the measurement of the force of blood against the walls of your arteries. When we write out blood pressure, we write it out as a fraction of two numbers. The first number is the systolic number on top, and the lower number is the diastolic number. So here's an example over here. A healthy adult blood pressure is, the marker is usually 120/80. And again, it's systolic on top, diastolic number on the bottom. The way that I remember which one is on top and which one is on bottom, and I've remembered it like this forever, is South Dakota. I don't know why. That helps me remember, but systolic, diastolic, South Dakota. It works for me, so I figured I'd share it. So the systolic pressure is, or the systolic reading is measuring the pressure in the arteries when the heart beats and pushes the blood out to the body. So when your heart beats, it's pushing blood out of the left ventricle, and it's taking all the oxygenated blood and pushing it out to the body, and it is delivering all that oxygenated blood out to the tissues, and oxygenating all of them, and then that picks up the deoxygenated blood. There's this whole capillary exchange that happens, and then the deoxygenated blood comes back up through the right side of the heart. So the crazy thing is that the left side of your heart is under immense pressure. That's why if you've ever looked at your heart, the left wall of the wall of the left ventricle is much thicker than the right ventricular wall, and it is because it's under a great deal of pressure, because it has to pump all of this oxygenated blood out to the whole body. And then the right side of the right chambers of the heart are the receiving chambers, and so it's just taking blood into the heart, and so that it can go out to the lungs and pick up oxygen and then be pumped back out to the rest of the body. And so the systolic pressure is basically measuring the force in the arteries when the heart is beating and pushing blood out to the body. And then the diastolic pressure is the diastolic number is the pressure in the arteries when the heart takes a break in between those beats. And so when it's resting in between beats, when it's in its relaxation phase, it is your diastolic number. Now, sometimes in the book it will tell you that the systolic number is the contraction phase and the diastolic number is the relaxation phase, and that is correct too. I figure if you're going to know, you should know what is happening in those two phases. So things that affect your blood pressure. Hypertension is one of the most commonly diagnosed diseases in the United States. It is more commonly known as high blood pressure. And even though it's really common, it does come with a whole host of potentially damaging long-term effects. So blood pressure that remains high for an extended period of time ends up wearing out those arterial walls and puts the patient at risk for things like atherosclerosis and heart failure and a stroke. So your arteries are constantly under high pressure, and they're very high pressure vessels as it is, but then when you have elevated blood pressure, so that means that your vessels, your arteries are under even greater pressure than they normally would be. They are just putting continual strain on it. So if you need a mental image, if you think of a water balloon that is constantly has this force on it. You know, the water balloon is full, and as you're filling that balloon, you can see it get fuller and fuller and fuller and fuller and fuller. And normally when it's completely full and it's at a good pressure, a good, fullness, you'll tie it off and that's that, right? And it kind of stays there But if you kept filling that balloon would keep stretching and stretching and stretching and stretching and stretching and stretching and stretching until it eventually burst, because it can't withstand the pressure of the fluid inside the contents of that little thin piece of latex. It's under way too much pressure from the fluid inside of it. And your arteries are kind of the same. Your arteries are much stronger than that thin balloon, but over the course of a person's lifetime, if they don't take care of their arteries, those arteries are going to eventually cave to the pressure that is being exerted on them from the force of the fluid within them. And so they start to become diseased, or they eventually get blockages, or they fail, or they cause a patient to have a stroke. So hypertension is a big deal, and is thankfully treatable with medications and diet changes, but is very hard for patients to get under control sometimes through those various diet and exercise changes. So the opposite of hypertension is hypotension, and that is low blood pressure. And low blood pressure generally isn't a chronic health problem, so there isn't too much to worry about there with low blood pressure, not nearly as much as hypertension. So we don't have too much to say about that. There are some classifications of blood pressure that you should know about, though, and where the numbers fall to make those classifications. So I put that here for you, the classifications for hypotension, for normal blood pressure, pre-hypertension, stage 1 hypertension, 2 hypertension, and then a hypertensive crisis. So this, I think I uploaded to Canvas also a chart for you with this information on it, so that you have it for your clinicals, but you should definitely take note of these and memorize them, make your own little chart, do something so that you have this information available to you. So as you're at your clinical site and you're doing these blood pressure readings, if you ever have a patient who is potentially in a hypertensive crisis, that you know to alert your provider. Also, one little side note, pediatrics have different blood pressure ranges than adults do, so you cannot necessarily use the classifications on this chart for a peds patient, depending on their age. Now, when they get a little bit older, they get closer to these ranges, but when they're littles, these don't work. Okay, so the equipment that we use to measure blood pressures, there is one piece of equipment called a sphygmomanometer, and I've got a whole bunch of notes up here. I'm going to talk to you about that in just a second. And the sphygmomanometer's job is actually to measure the blood pressure. The other thing that we use is a stethoscope, and so I drew a little stethoscope here to point out the pieces. We have earpieces on the stethoscope, and then the tubing which conducts the sound, and the sound comes up from the chest piece, and there's usually a diaphragm on one side and a bell on the other. So the diaphragm and bell have these the ability to be flipped around. On some of them, they have, sometimes you can turn them. Not all of them will have both, but they have, some do, some don't. I'm trying to think. Some of them even have specialized ones. So like if you can buy some really specialized stethoscopes, like for pediatrics and for cardio and all kinds of things. So all of them will have the listening chest piece down here, and they will have this tubing and then the earpieces. Then you have the whole point of the stethoscope is to amplify body sounds. And here's a fun fact for you, in case you didn't know. The stethoscope was actually invented like 100 years ago, 103 years ago, by a guy named René Laennec, after he felt super awkward about putting his head on ladies' chests to listen to their heart sounds. So he was a doctor, and he, before the invention of stethoscopes, had to lay his ear, on these ladies' chests when they were ill to listen to their heart sounds, and it weirded him out. He didn't feel comfortable with it, thought it was kind of wrong, especially in the early 1800s, and so he went on about his business and developed this sound amplifying piece of medical equipment that has been a piece of medical history since, and so still in use today. So procedures to take the blood pressure. There's the palpatory method, and this is this will only get a systolic pressure from this method. You can only get a systolic reading from this method, and so to get the palpatory, or to using the palpatory method and only getting the systolic pressure, what you do is you put a cuff on the patient and then you inflate it, and the whole time you're inflating it, you have your fingers and you're palpating the radial pulse. And so once you can no longer palpate or feel that radial pulse, then you note the blood pressure. And then the auscultative method is the one that you guys will be learning, and that is the more precise method. It uses the sphygmomanometer and the stethoscope together. The Korsakoff sounds are heard at the beginning with a tapping sound, and that at the beginning, when you first hear the sound, that represents a systolic pressure, and then when you no longer hear the sound, or when the sound ends and disappears, when those Korsakoff sounds disappear, that represents the diastolic pressure. So we will go through that too. All right, so this guy over here. The sphygmomanometer. This is an aneroid sphygmomanometer, and so I drew this dial on here because one of the hardest things over the years of teaching that I have with students, clinical class after clinical classes, it seems to be difficult for students to learn to read the dial on the sphygmomanometer. And so this is how to read it. So this, normally these dials go up to 300, but I didn't really draw this to scale, so mine only goes up to 240. It does the job though, you get the point. What you need to know is that each big mark on the dial represents 10 millimeters of mercury. Each of the 4 small marks in between the big marks represent 2 millimeters of mercury. And what you need to do to get the reading is add the lines from the bottom up to get the measurement. So going bottom, up. For example, where the arrow is pointing up here, pointing above, so we're pointing right here at this guy. The big line between the 40 and the 60, so here's my 40, here's my 60, the big line right here is 50, and then it's right at the first line above the 50, so the 50 plus 2 is 52. So the important thing to remember, and this happens every single time I teach these classes, these clinical classes, is I will have a student take a blood pressure, and then they rip the cuff off, and they pull the stethoscope out of their ears, and they look at me with like 1,000% confidence, and they're like 133/77. And then I tell them they are wrong every single time with 100% confidence, because all of the numbers on this dial are even numbers. All of them. There are never odd numbers in blood pressures that are done on these manual aneroid sphygmomanometers. So just know that. The only time you will ever see an odd number in a blood pressure reading is if it's done on an electronic cuff. Just throwing that out there. So keep that in mind. On electronic cuffs. The electronic cuffs, those are what's on our wallies in our clinic. So those provide a digital readout, and you don't have to use a stethoscope to hear the patient's pulse or hear the actual blood pressure. And, oh, you know what? Let me back up just a moment. I do want to say something here about this. And this little procedures part down here, this auscultative method, I do want to point out that when you are taking an auscultated blood pressure, a couple of things here. When you put the cuff on, you want to make sure that the cuff is pointed with the arrow. There's a little arrow on the cuff that says artery, and you want to make sure that that arrow that says artery is actually over the patient's brachial artery, the one that goes over here in their elbow area. Now, you won't know that that's their brachial artery unless you actually palpate and feel for the brachial artery. And in order to feel for the brachial artery, you need to go from the patient's pinky straight up their arm to their elbow and then feel for that pulse. Then you want to put that arrow on the cuff right over where that pulse point is, a couple inches above, like an inch or so, inch and a half, 2 inches above. That pulse point is where you're going to slide your stethoscope. You're going to put your stethoscope right over that pulse point, the brachial artery, and that's where you're going to listen for the blood pressure. Also, too, when you're holding your stethoscope, don't hold it with your thumb. I see so many people holding it with their thumb, but you don't want to do that because you don't want to accidentally, if you have a really good stethoscope, you could pick up little faint hints of your own radial pulse with your stethoscope, with your thumb on the stethoscope. So don't do that. Just hold it with your index and middle finger, and then you'll be good to go. All right, I digress. So back over here to Mercury sphygmomanometers. Like I mentioned earlier with the thermometers, the use of mercury was eliminated in 2017 due to safety concerns. The potential spillage of mercury contaminating the air environment led to the whole elimination of mercury, and so it was a big to-do, and now we don't have a lot of mercury things anymore, which is good for the environment, but there is concern over the accuracy of non-mercury sphygmomanometers. So they, and all other sphygmomanometers, electronic, aneroid, non-mercury, and otherwise, must be calibrated to have their measurements checked for accuracy and validated. So we want to make sure that the blood pressures that we're reporting out on patients are legit and that they are accurate, and so the only way that we can make sure that that is true is to have all of our sphygmomanometers calibrated. All right, so I think the last two sections we have over here are orthostatic vitals and body measurements. So orthostatic vitals are vital signs that are taken in 3 different positions. The patient starts out lying down, and then they sit up, and we take the vitals again. So we take the vitals with the patient lying down, and then they sit up, and we take the vitals again, and then they stand up, and we take the vitals a 3rd time. And so as the patient moves from a lying to a sitting or standing position, the blood pressure becomes lower, and therefore the pulse will increase. And so this will usually indicate fluid loss or cardiovascular malfunctions. And so that's the reason we do these orthostatic vitals. So sometimes this is a result of vomiting or diarrhea or prolonged bed rest. If the patient has orthostatic hypotension, it is an increase in the pulse rate of more than 10 beats per minute, and the BP drops more than 20 points. So if during if their vitals change from lying down to sitting up and standing by a pulse rate of more than 10 beats per minute, if their pulse increases more than 10 beats per minute from lying down to sitting to standing up, or the blood pressure drops more than 20 points from lying down to sitting up to standing up, then that patient would have orthostatic hypotension, which is also considered to be a positive tilt test. So just a heads up on that. And then our last little section down here on body measurements. So in adults and older kids, the height and weight are usually measured prior to seeing the provider when they come in. Infants, we measure the weight, the length, and the head circumference every time they come in. And when we're measuring weight, we went around to the nearest quarter pound. When we're measuring height, we only do that initially for adults, like the first time they're a new patient, and then annually for adults thereafter. And then if we are measuring BMI, we don't very often. Usually the providers do that, but if we have to measure BMI for some reason, it is calculated based on height and weight, and we use the CDC chart most of the time for BMI to help us calculate that out. And a calculator, thank God, because that's intense math. And I think that's it for vitals. Let me just think what else. Let me zoom out, make sure I didn't miss anything else. Nope, I think that's it. All right, I'm going to post this in Canvas for you guys, and that way it's there in case I end up having a sub. But otherwise, we'll go through it in class too. All right, thanks guys.